Ronnie Eichel is an example of the extreme benefit of combining specialities. I remember Ronnie as a neurological resident doing neurology at Hadassah and dealing with these difficult patients. And once we got him to realize that he should do intensive care if he really wanted to be a good neurologist, he's the proof of the pudding, that if you take two specialities and you combine them, you come out with a champion in his speciality. You know, when I started working with patients on ventilators, and you'll be shocked to hear it was in 1970, in the 1970s, when I first worked at the University of Cape Town with patients on ventilators, there was only one mode of ventilation. It was probably bad ventilation, BAD, but it was IPPV. That's all we knew. There was no other published, written mode of ventilation in the world. IPPV, intermittent positive pressure ventilation. The world's first heart transplant was done with a bird ventilator, which really was giving IPPV on a pressure-supported mode, but we didn't understand it at that time because the air was coming from a pressurized source, and the machine had a diaphragm, and it was just opening the diaphragm, letting the pressure blow in for a certain time and letting the pressure go out. And it was developing a pressure type of ventilator, but that's all we knew. We didn't know what the volume was. And probably one of the worst things that I think has happened in volume, in modes of ventilation, is the focus on volume as a mode of ventilation. And I'll tell you why. Even in the first slide, you'll see of the description, and this is the internationally accepted way of teaching ventilation, they talk about pressure, flow, and volume. And that's not really true, because pressure is what drives the gas flowing from one point to another point down a tube. Flow is the amount of flow that goes down the tube, and that depends on how the diameter and length of the tube is, because we know the length affects the flow and so does the diameter. And the only other component there is time. For how long this pressure exists between this point and that point, and for how long that flow that's able to flow at that pressure continues, which is time. And that's been extrapolated, unfortunately, in the world literature to volume. And the most confusing thing, I think, to everybody about ventilation is volume controlled or volume ventilation, because there isn't such a thing. Because the volume that you're measuring can be so many different things. It's the volume that the machine delivers. It's the volume that flows through a transducer. It's the volume that actually gets to the lung and where it goes in the lung. Because a lot of the volume, when we breathe spontaneously, goes to the alveoli, but 30% when we breathe with positive pressure goes to the non-ventilatory parts of the lung, the trachea and the bronchi and all the tubes. And then if there's any leak in the system, the volume is going out. And then there's the volume that you measure in the expiratory phase of the ventilator through a flow transducer, which tells you on the ventilator how much volume the patient got. Nonsense. So when we talk about volume-controlled ventilation, it only really works if the patient is completely sedated and paralyzed and there's no leak in the system. Then you can talk about volume ventilation. Ronnie gave a very clear description of the physics, but really it's pressure one side of a tube, pressure other side of the tube, flow and time. That's what gives you what gets to the alveoli and what gives you the volume. So when we talk about modes, and over the years, from the time I started, every time I went to a conference internationally, there was some expert from the United States or from Europe coming and telling us about a new mode of ventilation. And I'm going to go through some of the modes that have been taught, and the basics, spoke about the basics of ventilatory modes. Volume pre-assist, pressure pre-assist, preset assist, pressure support, and SIMV. Now, like I said to you, there was IPPV in the beginning, and you have to realize that some of the modes are exactly the same. Some of the things that are called modes of ventilation that are on the machine are exactly the same thing. There is no difference between volume control delivered by Marquette, IPPV delivered by Draeger, and SCIMV delivered by Hamilton. 3 different modes, but exactly the same thing. Exactly the same thing. What is the difference? And here comes the problem. That every ventilator manufacturer has a different way of designing and building their ventilator, and their demand valves, their expiratory valves, and their triggers are different. So they have to change the nomenclature to fit their ventilator. And this is the thing that you really need to understand, that most of the modes of ventilation are not designed by patients, definitely not designed by the doctors looking after them, but designed by the technicians and the engineers who are building machines and have to design a mode that suits their machine and promote their machine. This is the reality. But given that, let's stick with basics, and let's go to the basic principles of volume, preset, assist, control ventilation, where you set the tidal volume with all those limitations I told you before, and where you set the inspired, expired cycling. Now, I travel a lot around the country, and I see patients in all the hospitals now that I've retired from the intensive care Tadassa. I see patients in all the hospitals in the country, ICUs, intermediate care units, cardiac units. This is what I see. And I want to tell you that the biggest problem is how the IE ratio is set. This is the biggest problem. This is where the patient falls between the stools. In volume preset assist control, the breaths are ventilator initiated, controlled breaths, and like I said, in volume control, the best way is to have the patient sedated and paralyzed if you really want to give good volume control. But if the patient initiates it, it's assist breath, and you set the minimum frequency. Okay? Now that's the basis of volume control ventilation. And it doesn't matter whether the patient triggers a machine or the ventilator gives the machine. Those breaths are delivered as it's set, and there's a certain volume that's designed to be delivered. But as you know, if the pressure is too high, or the patient has resistance, or there's a leak, the volume doesn't get to the patient. So here's just to show you a graph of the pressure, flow, and volume showing that it's exactly the same whether the patient is breathing spontaneously or mechanically ventilated. And you set the minimum respiratory rate, okay? Sorry, I keep changing that. Then you set the inspiratory time and the inspiratory pause time, and here comes the problem. Like I said, in my experience, these are the 2 parameters that are not set properly. Obviously, the idea, as Ronnie clearly pointed out, to give a longer inspiratory time is a patient with ARDS, pulmonary edema, congested lung, reduced pulmonary compliance, to prolong the air in and improve the oxygenation. And because you deliver it slowly, the peak pressure that's achieved is lower and protects the lung. If you shorten the inspiratory time, you've got less risk of gas trapping, less intrinsic beep developing, and less effect on the cardiovascular system, as Ronnie clearly pointed out. But you may not get the volume to the right places in the lung that you want and oxygenate the patient properly. But basically, here comes another problem with the inspired time and the IE ratio of what do you change on the ventilator that changes that parameter? What do you change on the ventilator that changes the IE ratio? So first of all, there's the inspired flow time. This is the time that the inspired flow is continuing. Like I said to you, ventilation is pressure, flow, and time. So the inspired time determines what tidal volume the patient eventually gets, okay? Then there's an inspiratory pause time, where the air has reached its flow, but is held there for a period of time so that the volume can be distributed to the right place in the lung. And then there's the expiration. So we have inspired time, which is now a combination of the inspired flow time and the inspired pause time to give you the total inspired time. And then you've got the expiratory time until the next breath takes place. And this is the respiratory cycle time. Inspiration, expiration, including the inspiratory flow, pause, and expiration. Now, some ventilators allow you to set the IE ratio and inspiratory pause time as a percentage. Okay? That's all very well if the timing stays the same and the patient's breathing at the same rate. And here, when you set the inspiratory pause time as a percentage, you have the inspired flow, the pause time, which gives you a total of 2 seconds. And here, the 10% pause time is actually 0.6 seconds. Okay? Clear? What happens when the respiratory rate goes up and the patient starts to breathe and trigger that assist breath faster than the minimum set rate? Look what happens. All of a sudden, the total inspiratory time is 1 second. Because to make the time as a ratio of the breaths, it has to be according to the rate. So if the rate is slightly faster, everything shortens. So all of a sudden, the inspired time is shorter, and the pause time, which was 10% and set on the machine, comes down from 0.6 to 0.3, half the time. So what's going to happen now? It's quite clear. The patient is going to puff away against the ventilator. And the classical thing I see is a patient set on some kind of volume control ventilation, and they're puffing away, and everything is going haywire. And then Ronnie says what everybody says, "Ten lo dormicum, akoli je beseder." And that's what happens. Not because the patient needs a dormicum, but because the bad pattern of ventilation has been set in a patient who's not sedated and paralyzed. Quite simple. So in volume preset assist control, you set the minimum respiratory rate, the tidal volume or IE ratio directly or indirectly by turning the percentage pause, the percentage pause time directly or indirectly, and then you set the PEEP. Oi, now we have a problem. Now we got PEEP come into the equation. Now PEEP is also something that amuses me. It's one mode of one aspect of ventilation, PEEP, but I know at least 6 or 7 different kinds of PEEP. There's set PEEP, what you set on the machine. There's delivered PEEP, what the PEEP machine actually gives, because some machines you set 5 PEEP and they actually deliver 3 PEEP, and some you set 5 PEEP, they deliver 7 PEEP. You can see it if you monitor it carefully. There's the set PEEP, there's the delivered PEEP, and then there's the intrinsic PEEP, the PEEP you don't see that's inside the alveoli. The inadvertent PEEP, the unwanted PEEP. There's lots of different kinds of PEEP, and all of it is bad for people. So in volume preset assist control, you have advantages and disadvantages. It's easy to set. Everybody can understand tidal volume, 7 times your weight, 500 mils, 490 mils, 7 times your weight, that's the right amount. But if you're breathing spontaneously, 7 mils per kilogram is perfect. If you're having the air pushed in and 30% is going to your trachea and your bronchi, then 7 mils per kilo is not enough. You have to give 10 or 11 mils per kilo to get the same gas exchange. So what is volume set ventilation? The volume is having to give a hell of a lot more because of the mode of ventilation. But anyway, it's relatively simple to set, guaranteed minute ventilation according to what you see on the machine. Rests the muscles of respiration very well, particularly if you give sedation, lots of dormicum, and the muscle relaxant. The disadvantages, no synchronization. When the patient breathes fast, you get into big trouble. The patient starts to lead the ventilator, inappropriate triggering, excessive ventilation, lung compliance drops, alveolar pressure, risk of barotrauma because of the air trapping, and requires sedation for synchrony. The famous Ronnie Eichel dormicum story. Pressure control is reality. Pressure control is where you preset the pressure, similar to volume, except you reset the pressure. The pressure is preset, you change the inspiratory time, and there's no pause time. The pressure set, the pressure builds up, and the machine decides how much pressure it gives. The physics we've already been through. The problem is, where are you measuring that pressure? Do you know that some machines are measuring the pressure inside the machine, some are measuring it as it comes out the machine, some are measuring it at the patient's end, like this picture says, and some are extrapolating it from what's coming out the lungs and what the pressure is at the end of expiration. So every ventilator is doing it differently. You have to watch the graphs. That's why we put on the ventilator these graphs. The pressure, the flow, and the volume that's delivered. The time is there on the graph in terms of time, but you have to watch the graphs, and so much information is coming from the graphs to see if the patient is triggering, to see if the patient is overpressurizing, to see if the pressure is being reached, to see if the volume is actually being delivered. But bear in mind that when you're watching this, where are these measurements being taken from in that particular ventilator? You have to know, are they being measured at the end by a flow sensor? Are they being measured in the trachea? Are they being measured as it comes out of the machine? Or are they being measured inside the machine where all the valves are? And it makes a big difference. So pressure control has advantages. It's easy, relatively simple to set. It actually avoids too high ventilatory pressures, which are dangerous for barotrauma. It rests the muscle of inspiration. You see very often a patient tachypneic, you just increase the pressure support, and all of a sudden the patient is more comfortable. You increase the pressure. It improves oxygenation. Disadvantage is also not synchronized. Inappropriate triggering can cause excessive ventilation, tachypnea, and high-minute ventilation. And if you have changes in airway resistance or pulmonary compliance, the pressure that you had set before may not be appropriate for that patient at that time. It has to vary the pressure. Pressure support does exactly that. The first closed-loop form of a ventilatory mode in the world was pressure support ventilation, where you set a certain pressure and the patient decides how much of it they need. If they breathe well, the machine doesn't need to give the pressure. No flow comes because the pressure is already achieved. If you don't breathe well, the pressure has to build up. So the machine actually adjusts the flow and time according to the requirements of the patient. So the very first closed-loop system in mechanical ventilation mode was pressure support. And it works beautifully if the machine has a very good demand valve. And if the flow characteristics of the demand valve are good, and if there's enough flow in the system, because if the patient wants pressure support and they have to suck very hard to get the air, or the machine doesn't trigger it very quickly, the patient gets uncomfortable. So pressure support is all very well, but it has to be delivered by a good machine. And that's the problem, because some machines give good flow and some don't. The pressure support is quite straightforward, the graph. The pressure reaches a certain peak, it comes out. You can, in addition, with pressure support on modern machines, have a sensor which measures the expiratory volume. So effectively you can watch the expiratory volume, and you can have an alarm telling you if the expiratory volume is low. So your mode, although it's a pressure support delivered mode, you can have a monitor which tells you that the volume is being achieved. And that, believe me, is the most comfortable way to ventilate an awake or a patient who's not sedated or paralyzed, is some kind of pressure-supported mode of ventilation. The advantage is it's simple to set, avoids high pressures, better patient ventilator synchrony, and does unload the respiratory muscles to let the patient rest when they are tired. Because most people go into respiratory failure by a rapid shallow breathing pattern and get tired. So the support of the ventilation is really only to help them when they get tired, nothing else. The disadvantages, the older ventilators had no apnea backup, which is now modern ventilators all have apnea backup, so that goes away. And if you do have a change in lung compliance or resistance or patient effort, it can adjust the change the tidal volume. But I said you can have a monitor for the tidal volume. The pressure support of about 3 to 15 is required to overcome the additional work of breathing due to the demand of the ET tube and the tube. And this is something we often forget. You know, I always recommend to the residents when I'm teaching them to close their nose and put an endotracheal tube in their mouth, just to put it in their mouth, and breathe through the tube and see how long they last. Try it if you haven't tried it. Close your nose, take an endotracheal tube, put it in your mouth, and breathe through it. You don't last very long because the work of breathing becomes too high just because of the resistance in the tube. And that's why you need the ventilator to have at least a pressure support level about 5 or 6 to overcome those resistances. Everybody knows SIMV. That was the very first form of synchronized mandatory ventilation like we had in the early days. We had actually we had a big Puritan Bennett machines with a flow and a valve, and we had flow into it, and the person could take from the flow additionally, and all of a sudden the patients were able to be ventilated without sedation because they had SIMV. Patient gets a minimum amount of breaths, can breathe between the mandatory breaths, and you can see it on the graphs where there's the big breath from the machine, little breath from the patient, big breath from the machine, little breath from the patient, and then you can see if the little breath is adequate or not adequate, and slowly you can reduce the mandatory breaths. One of the easiest, most simple modes to apply and to use and to understand. Mandatory breaths are volume control, the pressure breaths are the spontaneous breaths are pressure controlled, and they synchronized with a patient breathing. If the machine is set with a very good trigger sensitivity and has a good demand valve, then the person can breathe and synchronize both the mandatory and the spontaneous breath, and it's the most comfortable. Now, triggering, here's a thing. Here's a thing, a confusing thing. There's pressure trigger and there's flow trigger, right? We all know that. But it differs dramatically from machine to machine. And I often see somebody come and use a new kind of machine. They've been using another kind of machine, and they say, oh, on this one we had to set the trigger sensitivity to 2 liters per minute flow trigger. On the other machine, if you do that, the machine is so sensitive and the demand valve is so sensitive that it starts making auto-triggering. So you have to realize that the trigger sensitivity on one machine is completely different to the trigger sensitivity on another machine, and you have to know your machine, you have to know how to set it. We set FiO2, we set SIMV rate, we set the SIMV period, we set the tidal volume or minimum tidal volume, or inspiratory pressure or minimum inspiratory pressure, the IE ratio, the pressure support level, and the PEEP. That's the settings for SIMV. Pressure support and SIMV type modes of ventilation are advantageous because they're very comfortable for the patient. They synchronize easy, and you do get a guaranteed minute ventilation, although it might be with a bit of tachypnea. The disadvantages, it's relatively complicated for the machine to deliver it properly. It's much easier for a machine to work like a horse and give controlled mandatory ventilation. For the machine to work with SIMV properly, with adequate sensitivity and comfortable for the patient, requires a lot more technology. So what modes should we use? What should we suggest? Mostly an apneutic patient who's not breathing, who's got a head injury, a neurological case, immediately the best thing to do is some kind of controlled minute ventilation value, either with pressure or volume and rate. If the patient can breathe intermittently, spontaneously, and you want to make him as comfortable as possible, you should use some kind of mode similar to SIMV. And if the patient is breathing spontaneously, adequately, it's just a matter of rapid, shallow breathing and reduced pressure support, pulmonary edema, or something like that, all you need to do is give them pressure support. So I hope I've made the modes more simple for you in terms of what you should do. An unconscious, not ventilating patient in Hachia or in patient with a head injury or thing can get mechanical ventilation, IPPV or CMV or control, depending on which ventilator you use, which mode. And if the patient is breathing spontaneously, you can use SIMV. And if the patient is breathing adequately spontaneously and just needs some pressure support, the best way to do it with pressure support. Any questions? I'd like to invite my colleague, Professor Vernon van Heerden, will now tell you how to troubleshoot my modes.